Okay. Hello, everyone. Today we're going to discuss difficult to control allergic rhinitis. I know all of you think allergic rhinitis, it's just a nuisance disease, but there are certain patients that are very difficult to control. And today we're going to do with several caregivers a problem-based learning approach to the diagnosis and treatment of difficult to control allergic rhinitis. This entails doing a case and then discussing some of the aspects of that case in a more didactic fashion after we've fully dissected the diagnosis and the treatment of difficult to control allergic rhinitis. So without further ado, let's get started. Shannon, take it off.
Hi, I am Shannon. Shannon Carver. I am in New York City, the Bronx to be exact. I am a nurse. I am also a certified asthma educator, and I am starting an asthma program in the city of Mount Vernon.
Thank you. Marcel.
Vishal Patel, adult pulmonary critical care physician from Michigan.
And Mary Beth.
Hi, I'm a nurse in private practice. I'm an RN and an asthma educator also. And I'm from Buffalo, New York, unless I said that already.
Okay, that's okay. We're reintroducing and Kathleen.
My name is Kathleen Ellis, and I am a nurse practitioner and also an asthma educator certified, and amongst other things. And I have worked with patients with asthma and rhinitis for my entire career. So I'm very, very interested in shared decision making and have used that throughout my career also. So I think it's going to be an exciting night for everybody.
Good. Well, let's get started. I need, since this is CME, to introduce myself, Don Buckstein. I too work in an inner city clinic now. I volunteer in an inner city Milwaukee clinic, and you can see I speak for a number of different pharmaceutical companies. And as I told you, I was the co-director of the Problem-Based Learning Institute. We do education, CME and non-CME interactive learning. Our objectives tonight are really to review some of the economic impact of allergic rhinitis, talk about it, talk about difficult to treat allergic rhinitis, and recognize that it's really total control of allergic rhinitis that we're trying to achieve for our patients and how we do that, and some of the negative impact that difficult to manage allergic rhinitis has on quality of life, some of the comorbidities, and then really one of the most important things that may be a little new to some of you is the role of shared decision making, especially when we come down to immunotherapy options, because we have a number of new immunotherapy options. So today what we're going to do is, you see in front of you a case. And I need a volunteer to read the case for me, the first part of the case, and we'll go one step at a time. So if I can have somebody read the first part of the patient's history. Anybody?
Okay.
Okay, you want me to go?
Shannon, go ahead.
Randy S. is a 30-year-old construction worker who presents to your office as a new patient with the chief complaint that my allergies are really bothering me this season. He narrates that the last few years I have been noticing frequent runny and itchy nose and eyes in the early summer for almost a full month, usually just taking one of those OTC antihistamines. You want me to keep going?
Yeah, do the whole page.
Oh, okay, the whole thing, all right. But they are making me feel tired and sluggish and not helping me as much anymore. I added a word. I almost had a bad accident at work one day with an electric saw when I was so sleepy, so I stopped taking those allergy pills. I really don't have these allergy problems the rest of the year.
Okay, how do you interpret just the information we have here? Patel, how do you, Vishal, how do you, Dr. Patel, how do you?
So, well, he's coming in mainly with the complaint of his allergies bothering during this season. and he has been noticing runny and itchy nose and the eyes, basically. So runny nose, itchy eyes, and itchy nose, and starts in early summer, so late part of the spring, and almost for a full month. And he has tried the medication. He had a bad side effect from it, near accident, I guess, when he fell asleep. So he stopped taking that, and he doesn't have that problem for the rest of the year other than that season, which is
okay. And Mary Beth, anything else you'd like to add with regard to just the history we have here?
Seems like he could use a good nasal spray too. Deal with this a lot. I don't really see very much other than what?
What other history would you want to kind of enlarge on this case, Randy? Find out a little bit more about him.
What he does for a living, his hours, where obviously he lives, what are his activities, whether they're outside, inside.
Okay. Kathleen, what about you? Any additional information you'd like?
Yes, I'd want to know if he'd ever been seen by a physician or a healthcare provider about allergies, or if this was something that just ran in the family or he just diagnosed himself. I'd ask him what over-the-counter antihistamines he was taking, because he could have been taking Benadryl, and it's a wonder he didn't, really have an accident. Just kinds of things like that. What's he tried? What's he done? It has he been seen anybody about it? How long has he had it? Did this continue since childhood, or is this something new?
How about Shannon Vassell? Any additional information you'd like?
No, I was going to say, oh, sorry.
Go ahead, Shannon.
I think there's like a little delay, so I don't see it. The only thing I was going to say, but Kathleen just said it, was I know he said one of those OTCs, but maybe if he doesn't know the name, if he could describe it for us or something, so we kind of know what he's on that's making him tired. In addition to, like, is his job outside during those summer months?
Okay.
Also, I would like to know the timing of those medications, how many times he has been taking it, once a day, twice a day. Also depends on what he's taking, how many times and what time is he taking, before going to bed, after, in the morning, what time.
Okay. So here we've got some more history. Can I have a volunteer? Vassell, possibly.
Okay, I'll go for it. All right, continued history. We have the Rio systems, negative, except his wife tells him that he snores loudly and keeps her up since his allergies have gotten so bad. His past medical history, he remembers that the onset of his respiratory symptoms began about age 5, initially with frequent runny and itchy nose and eyes in the runny nose and eyes in the spring and fall, but after several years became year-round. Although he tried various medications, he finally saw an allergist by 5th grade and went on allergy shots. He did so well after about 4 years, he was able to stop his shots and has not had problems with his allergies again until last few years. He denied any other serious medical problems except that he takes an albuterol several times per year for up to a week when he gets sinus infections 2 to 3 times per year, mostly in the winter. His environmental history, he lives with his wife and 2 sons, 6 and 8 years old, in a suburb of your city. They have no pets, no one smokes in the home, they have mostly hardwood floors and a new mattress. Okay.
You can finish off the history here.
Family history, his mother has a long history of hay fever each spring and fall, and his father has asthma. Social history, his real passion is coaching his son's Little League baseball teams, but notices his allergies are allergies are most intense during their season.
Okay. So now you got any other historical facts any of you wish to ask?
If he knows what allergies, so he saw the allergist. I don't know if he remembers what he was told to be allergic.
He's not sure, but we're sending for those records, so we'll probably get them hopefully soon. Any other history that you want? Okay, so what are you gleaning from just the history we have? How do you interpret the information you have here?
So he does have predisposition to the allergies, right? It sort of runs in the family. He had a good control with the allergy shots, and then got better. So 4 years after diagnosis, when he was 5, so maybe age 5 to age 9, he was good. And after that, it got better until a few years ago. So now he's what, 30 something?
Yeah.
So he had good period for about 10, 15 years in between when he was good.
Okay, and Mary Beth, how do you interpret this information? What's your
I'm wondering if he doesn't have, if he doesn't have asthma too, since he's also using albuterol, and that, I can't remember what was on the other page. If he really should go back to allergy, be retested to see what else, because allergies do change throughout the years.
What would you think he might be allergic to with those?
Usually around that time of year, I mean, here in this area, it's usually going to be the start of your grasses, and trees are actually early spring, so your grasses and weeds, especially if he has the history of being with his son in baseball, I think it was.
Okay. Kathleen, what do you think about the rest of the history?
I think he really needs to go, back for another evaluation, clearly, because it sounds like he fell off the follow-up here or whatever.
Okay.
I would evaluate him for asthma also, because, with that family history of both parents having one asthma, the other one allergic rhinitis, it's likely that he could maybe have asthma if he's using albuterol.
Okay. So what's the next thing you want to do? Anything? If he's in your office, you've got history from him, what are you going to do next?
Physical exam.
Okay. So, can I have somebody volunteer to read the physical exam for us?
I will.
Okay, thank you.
He is a well-appearing Caucasian young man in no acute distress, noted to be rubbing his nose frequently with several sneezing paroxysms. Vital signs: respiratory rate 14, heart rate 88, height 5 feet 11 inches, weight 180 pounds. Eyes: bilateral infraorbital edema with erythematous bulbar conjunctiva bilaterally. Tympanic membranes, normal color and appearance. Nose, pale blue and very edematous mucosa bilaterally with clear rhinorrhea. Throat, normal colored pharynx with cobblestoned appearance, but no postnasal drainage noted. Chest, clear to auscultation.
Okay. How do you guys interpret this information along with the history?
Allergic.
Go ahead.
Yeah, so I'll go ahead. So he does have the rhinorrhea that you can see on the exam. This BMI, probably, if you calculate, would come out about normal, or near normal, maybe slightly overweight. The eyes and the nose definitely have the signs of inflammation there, bilaterally. So it's not a unilateral problem. It's all over in the eyes and the nose. The cobblestoning can be seen with the postnasal drip, although there is no postnasal drainage noted. But but it could lead to the cobblestoning. And the lungs are clear, so no wheezing is mentioned here, at least.
Good. Shannon, what's your opinion?
So far, I agree. I think he's definitely showing signs of some irritation from the allergy with the extra runny nose, and with his eyes, he's rubbing his eyes, or rubbing his nose, it said. So, yep.
Great. Okay. Well, we've kind of got a would you guys say this is a typical case that you might see on a Monday morning in your practices?
Yeah.
Yes.
Okay. What's your impression? Do we have some diagnoses? Can I get first, Mary Beth, you have an impression?
Definitely an allergic rhinitis.
Okay. How about a second one from Kathleen? You have something, another impression? Jeez.
I think he has allergic conjunctivitis also, but I would rule out asthma too.
Okay.
At some point.
Okay. And what's your evaluation? Shannon, what are you going to do to evaluate this young man?
I'd like to see him get probably two things. Another prick test, skin test for allergy, see if we can't narrow down what it is, and a pulmonary function test.
Okay. What do the rest of you think?
Yeah, agree. The spirometry with bronchodilators and the skin testing.
Anybody have any additional things, evaluation they want to do?
Sometimes I would do the RAS testing too, the blood test.
Well, either skin tests or blood tests looking for IgE to different things. And in particular, I think you mentioned grasses, and then his impression. Any other impressions or rule outs? Okay.
Well, he had the snoring, so.
Snoring, okay. What do you want to do about that? Any evaluation for the snoring?
Get an X-ray of the adenoids and tonsils.
Okay. Maybe an X-ray of the adenoids and tonsils. Anybody else? Okay. Okay. Well, the other thing is the plan. What do you want to do for this young man? He's in your office. You plan to send him to the allergist for skin testing or plan skin testing on a day. But until then, what are you going to do treatment wise? He says, Doc, how are you going to help me? I got to do my little league team in the next few weeks, and I don't want to be miserable. What are you going to do?
Start him on a like a fluticasone.
Nasal corticosteroids.
So a nasal corticosteroid.
Exactly, that's what I would do too.
Okay. Anything else you want to do? Any other treatment, or
You
just
could
the
do an antihistamine, but you'd have to work around this allergy skin testing.
Okay. Okay. So let's get a little more history. You recommended that he get an OTC corticosteroid nasal spray. I think you said fluticasone. There are a few out now, and give it to him twice a day. And over-the-counter eye drops you guys didn't mention, but that's something that was suggested. And he does well, but he doesn't return for follow-up visits. Okay, he's doing well. However, he returns 2 years later in September, taking his nasal spray off and on throughout the year. Staying the nasal spray and eye drops seem to help the last 2 years, but they don't help anymore. And while my symptoms the past 2 years have become all year round now, and most severe in the early summer when I really want to coach the team. This year has been really severe, many months from early summer to early fall. Also, I have a horrible cough now, feel like I'm wheezing almost all the time, and I have a sinus headache. Okay, this time your physical exam is only abnormal for some erythematous bulbar conjunctiva, pale edematous inferior turbinates, a lot of rhinorrhea, and a productive cough. His O2 sat was 97%, and you hear some wheezing bilaterally. So what's your impression now? Shannon, what do you think?
He should have come back for a follow-up. He should have followed through with all of his testing. No. I'm going to say something else, and I don't mean, I'm not being funny, but I don't know. Well, I guess if he was getting the medications over the counter, but I'm hoping he wasn't using these prescriptions for 2 years because, one, they're not working because they're outdated, or two, why was the doctor still ordering them for 2 years without seeing him?
I think he was getting over-the-counter nasal
Yeah.
steroids.
It says it. It says it there. But yeah, definitely, I want to impress upon him how important it is that now we maybe need to do this testing and see if, like, I can get him in for a pulmonary function test and things. I know with this horrible cough and this it's non-productive, so maybe we'll even get him in and give him a breathing treatment here in our office. I don't know if other offices do that, but we do at our office. Because he's definitely got himself in a much worse situation.
What do the rest of you think? Kathleen, Mary Beth?
First of all, I would feel guilty that I never really got hit home, based to explain to him, the importance of adherence and coming back at regular visits, regular times, so we can see and evaluate whether things are working, because only he can tell us that, and sometimes it takes, a little while to see what's the best thing for him. So I think we definitely need to do some, education and, some evaluation, or teach him, and make some shared decisions with him about, does he want an antihistamine or, the nasal spray, and things like that, and then talk a little bit more about how this wheezing and stuff has started, and see exactly what's going on here.
Okay, so what are your impressions? Mary Beth, do you have any new impressions before we had allergic rhinitis, possibly asthma, allergic conjunctivitis? Any new impressions?
No, I just think his allergies have just gotten worse. He's hit his threshold, and everything now that he might have not had a problem with is now reacting with them.
Okay. Any new diagnoses?
Well, the chronic sinusitis now, his sinuses are being affected now.
So he may have some sinusitis now. Okay.
Right. And the asthma, because the wheezing is being manifested now, the cough could be related to that or postnasal drip.
Would you want to classify his asthma, any of you? Give it a more of a descriptor?
Mild, intermittent. I mean, we don't really have a good history yet, though, of what his asthma symptoms are, because he's wheezing now, but we don't know what trouble he has had really yet. We need more history on that before you can really classify it.
He says he wheezes on and off with activity, and lately he's been wheezing almost every day using
So
his
he's probably, well, he's not well controlled to begin with, so he's probably more moderate.
I would say moderate to severe persistent. I agree.
Yeah.
Yes.
Okay. So what are our recommendations? What do you guys want to do?
Well, again, to do the breathing test and give him the inhaled and nasal corticosteroids again. Give him the inhaled corticosteroids now, of course, after the breathing test, to control his wheezing and cut down the inflammation. If he's feeling bad, I would give him the steroids right now, the oral steroids, systemic steroids right now, to help him feel better over the next week or so. And that would be to start out with, along with some antihistamines.
What do the rest of you think? Any other ideas of recommendations? Or other lab, or we want to get pulmonary functions, want to do skin testing, anything else? Okay.
I also want to get a chest x-ray maybe. just to make sure
Maybe
nothing.
chest X-ray.
Peter,
Okay.
idea of it.
Well, Randy returns for a follow-up visit after the weather has turned cooler. He notes he got much better recently, just having some daily year-round congestion he just deals with. His wife told him to quit snoring so loudly after the weather, told him that he quit snoring loudly after the weather turned cooler. He still feels fatigued, even though he is not on any oral antihistamines. He stopped all his medications 2 weeks ago and wants to discuss what his other options are and hopefully prevent such a frustrating symptoms next summer through fall when he really wants to do the Little League team. What do you discuss with him now, and what is his informed personal preference? You've referred him to the allergist, but he can't get in for a few weeks and doesn't especially want to pay another copay. And he's saying, you know, can you do anything for me as a kind of a primary care physician? Any thoughts? What do you do? What do you do with him now? He tried the nose spray. It helped a little bit, but still, he wants to know what other options he has from that'll control him a little better.
You can try the nasal antihistamines. Meanwhile, he gets to the allergist.
So you think the antihistamine will work better than the nasal steroid spray?
In conjunction with the nasal corticosteroids.
What do the rest of you think?
I think he needs to, you need to sit down with him and really explain how everything works. And you can't just take it randomly like he was doing things before. You know, we have to, and I would make an actual plan with him after we chose what we wanted to do and get him to buy into. You can't just take inhaled steroids like here and there. And, you know, I just don't think he really understands how to take anything.
It sounds like he just needs a lot of education, that things need to be treated before they actually start. So before his season really starts, to get him started on his inhaled corticosteroids, his nasal corticosteroids, his antihistamine, along with getting into the allergist and maybe getting his shots back on.
Okay.
For sure.
Any other thoughts?
I think also because he's been complaining of a lot of fatigue, and even though he's not snoring now, he's still fatigued. So I would want to just kind of encourage him to continue follow-up to see if he's still having a lot of this fatigue, and have him assessed for his nighttime breathing, because he may be having some sleep apnea, but it could be related to all the inflammation.
And DeSalle, any ideas?
I agree. I mean, he will probably need the sleep study because he's doing that. Oral histamines we are trying to avoid because of his fatigue, which is understandable. And that's why I recommended the nasal antihistamine in addition with the nasal corticosteroids until he goes to his allergist.
So
and of course,
antihistamine and a nasal corticosteroid. Okay, great. Any other thoughts? Any other thoughts? Well, I'll tell you, if I was in primary care, this would be one of the most frustrating patients I would ever see. Allergic rhinitis is a very, very frustrating disease when it's not easy to control. A lot of times, over-the-counter antihistamines, over-the-counter nasal steroids, even used intermittently by some patients, will control very mild disease. And most patients, thank God, have easily controlled disease. But there is a big section of patients that don't have easy to control disease. And now we have a lot of things that we can do for allergic rhinitis that we didn't have so many options in the past. And a lot of it is personal preference. And whenever we talk about diseases where there's not a clear-cut hierarchy of how you treat that disease, where there's personal preference involved, and that's a great many of chronic diseases, something called shared decision-making comes into play. And I think you guys hit the nail on the head when you said he's probably not very adherent. What's the average adherence for using nasal steroids over a year? Have any idea? Take a wild guess. Come on.
50%.
Say
Looks
30.
Could
30
get 10 or 12. What do you
I was
think?
saying 20.
20 over a year. The average where you should be using about 1 a month, about 10 a year, is about 2. Okay? Dramatically, even worse than inhaled steroids. So patients really oftentimes have problems with nasal steroids, usually because of 2 factors. 1, they don't work very well. And 2, and they do work in most patients very well, but in some patients they don't. And the other factor is side effects. So all it takes is a little nosebleed or nasal irritation or bad taste or almost anything. People just don't like spraying things in their nose for them to stop. But we have up here shared decision making. How would you guys define that? In a patient like this who's not very adherent, still having problems, how do you define that?
I would say it's sitting down, the healthcare provider sitting down with the client and talking, saying there's several ways we can treat this and delineating those. What are the, pros and cons about each one? And then, asking the patient what does he think, he would like to do?
Excellent. What do the rest of you think? Any other thoughts?
Yeah, agree. Well, I guess that to find out the factors which are preventing him from using this with compliance would be important, whether it's a lack of education, whether it's not being effective, whether he thinks that they are not needed, or whether he thinks that they should be just use PRN on as needed basis. And that will be important to find out in process the shared decision.
Okay. Any other thoughts about what shared decision making is?
To see what his goals are and what his perceived outcome would be or should be.
Okay.
Yeah.
Excellent.
Like, that's what I was going to say. What was important to him and really impressing upon him, like his goal is to be able to coach the little league and then providing him the evidence, and then that third piece taking like what's preventing him, what factors are there, and then kind of, educating based on that, building off of that.
That's true. And really in our patients, one of the things we don't kind of establish at the beginning enough, I think, is their personal perception of their disease, the PPI, their perception of their disease and their goals of therapy. Most of us, if we ask, do we do shared decision making, we'd raise our hands and say, of course we do shared decision making with most of our patients. And most of us have heard of it and really ascribe to the idea or the principle of shared decision making. But does anyone really do it? I know that part of my interest in shared decision making is the fact that I really didn't do a very good job for the first 35 years of my practice, and only the last 5 or 6 years where I've really become interested in and really practiced and read about how to do better shared decision making, that I've really done it, I think, a little bit better. Why is it important? Because the patient is the best person to tell you their preferences. They're an expert in their disease. Many patients feel, don't do anything for me without me. And there's huge benefits to shared decision making, because the one thing that will improve adherence every time is to do shared decision making. Now, it may not make adherence perfect, don't get me wrong, but it's a huge benefit for the patient. And you hit the nail on the head when you guys said, let's get patient preferences. What are important to him and why the patient isn't using the medication. And so the next step, I think anybody would agree, if the medication isn't working and we think he's taking it, or at least the majority of the time, would be a discussion about immunotherapy. And do you guys ever refer people for immunotherapy or talk to people about getting immunotherapy? And for that matter, do you have an idea of what it is? Anybody?
Yeah, I refer, or our doctors refer, I should say, to the allergist if their allergies are really out of control and it's triggering asthma flares. I actually did work for an allergist before I worked for this pediatrician also, so I am familiar with a lot of the immunotherapy.
Mm-hmm.
What do the rest of you think? Any ideas?
Yeah, so basically the desensitization therapy, after finding out what he's allergic to and target that therapy according to what he's allergic to. It could be the mixture of multiple things or one or two isolated things that he's allergic to, and give him that periodically over a period of few years to control the symptoms. That's
Excellent.
what
So you guys have a great idea. We have two forms of immunotherapy today, or desensitization, and it's a very simple process of giving somebody what they're allergic to for them to build up a natural resistance. It's interesting, after 110 years of it being around, we still don't know exactly how it works, but we have two forms of immunotherapy: SCIT, subcutaneous immunotherapy, and SLIT, a sublingual immunotherapy. The subcutaneous is a shot. The SLIT is sublingual, is a little tablet under the tongue. And so do you guys know of any shared decision-making tools for allergic rhinitis that would help him make a decision about whether he wants to try more nasal steroids, nasal antihistamines, combinations of nasal steroids and nasal antihistamines, or whether he wants to consider one of the forms of immunotherapy? Are you guys aware of anything that can help you with this? Good. Then this will be good. So what I want to do now is to convince you that we need to do shared decision making with more of our patients, like Randy. Allergic rhinitis affects about 35 to 50 million people. And most of those people are seen in primary care, and most of those people get better with self-treatment oftentimes and don't even go to primary care with over-the-counter medications today. The prevalence, though, is increasing kind of at an enormous rate. In adults, we're up to 10 to 30%, children up 40%. 59% of patients consider their symptoms to be moderate or severe. 20% of patients believe their healthcare provider doesn't take their symptoms seriously enough. They think of it as a trivial disease. But it's anything but that. If you're going to school, 2 million school days are lost. The economic effect on caregivers has really not been established. But what has been established is the loss of productivity that is huge. About $3.8 billion are lost in productivity just due to people taking sedating antihistamines and decrease in work performance. But like Randy, only 1 in 8 patients ever even seeks treatment. And here's some kind of statistics that I think are quite alarming. 31% of patients aren't satisfied with their current medication. 88% want more long-lasting permanent relief, which is something we probably all want. And 60% are interested in different allergy meds. If you look at the top, it takes 8 to 10 years of symptoms onset to get to the doctor oftentimes. And 47% of patients are on multiple medications, as we started adding them to Randy, but only about 40% are on scripts and over-the-counter medications. And again, we talked about the high burden. What we haven't talked about, but you guys really jumped on it right away, is the overlap or comorbidity in allergic rhinitis. There's an old saying that it's one airway, one disease. So allergic rhinitis obviously is associated with rhinosinusitis, it's associated with sleep disruption. In younger kids, it's associated with recurrent otitis media and otitis media with effusion. And of course, it's associated, it's kind of the analog of asthma in the upper airway. It's associated with asthma. So again, we talked about allergic rhinitis having a huge effect, as you can see here, more than anything else, adding to productivity decreases in the workplace. And this is just one study in wellness, and you can see here how it compares. And even though it's not as serious a disease, certainly as diabetes or coronary artery disease, it certainly rivals all those because so many people have it and lost productivity. I'd like you to think of allergic rhinitis and asthma the same way. It's really control of that disease that we want. And we've got impairment and we've got risk. And impairment really is like asthma, has to do with activity, sleep, troublesome symptoms, an effect on your quality of life and your work and school activities. The risk is the exacerbations when it gets really bad. You can't sleep at night. Other comorbid conditions, like in Randy, his asthma, possibly sinusitis, sleep problems, all got worse. And the disease progresses. If you don't control the disease, in many patients, it will get progressively worse. And then again, you even saw in Randy, although that wasn't real severe, adverse effects of the medications we give him. Just like with asthma, it's not a bad idea to do a survey, a questionnaire that gets at rhinitis control. And we have a really good one. And it's 6 simple questions. It's called the RCAT. And if your score is 30, actually 21 or above, you're in the green zone, you're doing well. But if you're 20 or below, you're not doing as well. And you can see here that the questions have to do with nasal congestion, sneezing, watery eyes, sleep, other allergy symptoms, avoiding activity, and is your nasal and allergy symptoms you feel well controlled. So just like the ACT, it gives you a mirror into their control, and it's something you can track over time. RCAT is a very useful tool. It's used in almost all our research studies. And in this study at 6 months, more than 70–80% of respondents had clinically meaningful improvement as defined by a greater than 3 increase in their RCAT from a baseline of 58%. This was in a study looking at the control with nasal steroids. So what are the guidelines say about treating allergic rhinitis? Well, they say for mild or moderate intermittent disease, you can use any of these. Nasal steroids, non-sedating antihistamines. We have a number of good choices over the counter. Leukotriene antagonists work, nasal decongestants work, and oral decongestants, but aren't recommended for long periods of time, but don't have that great improvement in symptoms. Certainly nasal steroids are the treatment of choice here, along with avoidance of allergens, but this was a guy who loved to teach his son and their friends about baseball and coach the baseball team. But if you look at where immunotherapy comes in, it's not reserved in any of the guidelines for just very severe disease, but really when you start to get moderately severe disease, even intermittent, you should offer that as a potential choice of therapy. And we'll talk about why that is. So Randy's treatment plan, just as you guys talked about, he should get tested to find out exactly what allergens are causing it. We have a great idea, maybe tree grasses or weeds, especially grass. You can reduce his symptoms from with pharmacologic therapy, but then you want to talk about immunotherapy and what makes the most pharmacoeconomic sense for him, given his insurance, his ability to come in for shots, or whether he's afraid of needles. All these factors, his employer, even the community he lives in, their perspectives all kind of come together in making those decisions. And really it has kind of a little checklist that I use for asthma and for rhinitis. Have I looked at all these factors in their control, their quality of life, their symptoms, whether I've communicated with them. Literacy, cultural competency, all are factors, and pharmacotherapy. And then I think about non-adherence, how I'm going to improve adherence, and whether there are any comorbidities that I can control, like his asthma, his possible sinusitis, or other problems. And based on that model, we try and get his goals of therapy. His goals of therapy may be no nasal ocular symptoms, no complications. He doesn't want to store. He doesn't want to have disruptive. He wants to be able to coach the baseball team. He doesn't want to be sedated. And he wants something safe that he can take kind of when he needs it, that's going to give him lasting effects. Now, that may not be possible with the current medications that we have available, but most of the times we can go a long way to meeting some of his goals. And one of the things that in primary care you have to ask, is he ready for specialty care? And why isn't his therapy being used? Is it doesn't work? Or there are other factors with his non-adherence, can't afford it, doesn't like the smell, doesn't like the taste. And how practical is avoiding allergens, and how practical would immunotherapy and what type of immunotherapy? And really what we want to do is find the right therapy for the right patient. So I'm going to ask you, do you guys think Randy's a candidate for immunotherapy? Shannon, what do you think?
Yes.
Okay, why do you think he's a candidate?
Well, he's had these ongoing issues. Again, like you said, it doesn't have to be only for the severe. However, being that he's had this issue with the allergy since, 5 years old or previous to that, I think he definitely would benefit as long as he's going to be consistent and follow through. I don't think it's something that he needs to start if he's not going to comply. And I know that's a bad use of the word, but if he's not going to be consistent and continue to treat this allergy.
Excellent. And Visal, what do you think?
Yeah, I agree. I mean, if he understands the need for follow-ups and the need to visit the allergies frequently, then yeah, he may be a candidate for the immunotherapy.
And Mary Beth?
Yeah, I agree, although I'd still be very worried he wouldn't follow through with the immunotherapy, knowing that it's basically once a week for so long. Mm-hmm. That would be a very big concern, because if he doesn't follow through, it's not going to benefit him at all to even start.
Okay. And Kathleen, what do you think?
No, I think it would help him. But again, before we ever started anything, we would always, really sit down and talk to people, to see if that would work for them, if they could come. We did have some evening hours, different kinds of things, but, while you're cleaning things up, they can check their insurance or different things and, talk to their family about it or whatever. But they definitely have to understand, because as Mary Beth just said, if they're on the same dose for, a year or something, it's ridiculous.
So we have to impress upon Randy, and we're going to talk about that, the pros and cons. One of the big pros with immunotherapy is it's the only thing the FDA lets them say changes the disease, is a disease modifier. It decreases symptoms. It may offer a long-lasting remission in many patients. It certainly decreases sensitivities, and those sensitivities often come back when it's stopped. And it currently can reduce outpatient services and costs. It tends to be, allergy immunotherapy tends to have a very good cost-benefit ratio. The kind of immunotherapy we've used over 100 years is called SCIT, and you're right, that's the one most of us think about in this country. Again, it's a natural form. It giving people what they're allergic to in their own body develops this ability to suppress the allergic reaction. Okay, it's effective not only in allergic rhinitis, but in allergic asthma and maybe some patients with atopic dermatitis. It certainly has been demonstrated in patients that have one sensitivity, but there are good studies with SCIT that show even with multiple sensitivities, if you give the proper dose, that you can get improvement, even people that are what we call polysensitized. Some of SCIT's benefits and concerns are it's effective in seasonal rhinitis, it induces long-lasting remissions. It's effective in perennial rhinitis, such as dust mite and animal danders. And again, evidence may suggest, indirect evidence, that's a little more effective than SCIT, sublingual immunotherapy, in seasonal allergic rhinitis. Evidence-based in children's less convincing. We need more studies, but still there's some in children. It has local side effects. There's no question. You get a little pain, swelling, usually well tolerated. It requires administration in a medical clinic, and adherence is a problem. Adherence is a problem in taking medication, and certainly as you guys jumped on top of it, adherence is a problem here. And you want to be sure that the patient is interested in going forward. And again, not a lot of comparative studies, very little of SCIT and SLIT. SCIT in children with allergic rhinitis does decrease the risk of developing asthma. It can decrease hyperresponsiveness, especially in some of the childhood studies, airway hyperresponsiveness. It reduces the risk of developing new allergies. So if you start a kid on immunotherapy, let's say to dust mite early on, it will reduce them becoming more polysensitized. It gives long-lasting relief, and very high doses of sublingual immunotherapy appear to be very safe, as has SCIT therapy. Some of the benefits and concerns about SLIT or sublingual, again, the same thing, induces long-term remissions, and especially in perennial allergic rhinitis to dust mite. Indirect evidence suggests SLIT is better tolerated than SCIT because it is sublingual, but you have to take a tablet every day. Again, it does cause local side effects, but it can be self-administered, but adherence is still a huge problem. And again, no real good comparator studies. So again, we know that SLIT has been effective, especially in Europe over the last couple decades, and is used more extensively. But we now have products in the United States to grass and ragweed, dust mite, with other products on the way to be used. So some of the limitations of SCIT are you got to come in a lot. You got to come in once a week for several months and every 3 to 4 weeks. Their systemic reactions occur, although very rarely, and cost depends on insurance coverage. And a lot of times, I think Kathleen said it, we have them check their insurance coverage, and so they know what they're going to have to pay. Again, added value is that it can modify the disease, and again, the problem, treatment adherence. Now, I don't want you to go through, there's a lot of words here, but I want you to see that what we need to do is compare for patients so they understand it in a way they understand, in a literacy level and a cultural competency level that they understand, subcutaneous versus sublingual, SCIT versus SLIT, under the skin, under the tongue immunotherapy. And we want to go through all the information I have, tell them how they're going to increase their doses with SCIT, how they have to stay on it with the subcutaneous for at least 3 years, and what they can expect. But that you can do multiple allergens. With sublingual immunotherapy, you really have the grasses, ragweed, and dust mite. So if they're primarily allergic to those, even though they have other primary allergy by their history, and your assessment is that they have dust mite or grass, then treatment can be very successful. Again, SLIT is unable to mix all these multiple allergens together like we do with the under the skin, under the tongue. We're not able to do those multiple allergens. So if you do a checklist for patients, and this is one I like to use, is that all of them reduce symptoms, reduce allergy medication, and they improve quality of life, decrease asthma chance. But available allergens for SCIT, there are more of them. multiple allergens. You have to do it in the doctor's office, whereas SCIT you can do at home. Again, time of treatment, no clear answer to SCIT yet. We think at least 3 years. There's some GRASS studies that suggest 3 years may be enough. But with the SCIT, we know 3 to 5 years, and after 3 years of treatment, you can get extended improvement. With SCIT or sublingual under the tongue, we know maybe a year or two of improvement afterwards, but we don't have those long-term studies. Again, the side effects of these are, when you give it under the skin, systemic reactions, large local reactions, okay? With the SCIT tablets, sometimes you get some itching or swelling under the tongue. Usually that goes away within a week or two. Again, you go over those side effects. These go over the side effects, especially death. Fatal or near fatal reactions to SCIT occur rarely, about 1 in every 2.5 million injections, and about non-fatal severe reactions about once in every million injections. Whereas with SCIT, it's almost unheard of to have a systemic reaction, less than 1 in a billion doses. So again, very, very rare. Again, side effects, you get the swollen, itchy arms. Yeah, very rarely do you get systemic reactions, but some people are afraid of needles, and you got to wait for 30 minutes in the doctor's office with the SCIT because most immediate reactions occur very quickly. With SCIT, because it's so safe and such rarity to these reactions, basically you can just get that itching under the tongue. I've not seen nausea, diarrhea, cramping, but they may occur very, very rarely. And then subcutaneous immunotherapy under the skin, again, you can do multiple allergens. With sublingual immunotherapy, you can do one main allergen. It will work. Let's say you're allergic to dust mite and tree pollen, and the tree pollen season you're not that ill. You could do it to dust mite and get some improvement. Most of the patients that have been on the studies with sublingual immunotherapy were what we call polysensitized. They were allergic to multiple different allergens, okay? And then what does immunotherapy cost? Well, that is so varied. You need an EpiPen. Really, I would have an EpiPen for both, okay? So that's not going to minimize cost. Copay for the tablets are often a pharmacy benefit, whereas the shots may be a medical benefit. So it depends on billing codes, insurance, and you really have to check with your insurance to really tell. Again, a study showed the cost of healthcare for children with nasal symptoms who received SCIT in a big Florida Medicaid database was 1/3 less than children who did not have SCIT for their allergic rhinitis and allergic asthma. So if you look at huge databases, you see that this therapy is really cost effective because it gives you lasting remissions when you stop. Now, here's the real kicker. If you want a really good shared decision-making aid, you can go to the American College of Allergy website, and you see at the bottom, this is a paper one that we use, and you can get that and copy it at allergyrelief.acaa.org. That's the American College of Allergy, Asthma, and Immunology. And on their website is a great shared decision-making aid. And we go through this shared decision-making aid. It takes just a minute with our patients, just on paper or on the internet. And it asks for the patient's preferences, their current approach, what are the different types of immunotherapy, what are the cost concerns, and then really can outline the difference between allergy shots and allergy tablets. So I recommend it. It's all about communication. The biggest problem with communication is the illusion that it occurred, and that's very true. So it may be my perspective that Randy needs immunotherapy, but may not be his perspective. He wants to sleep, he wants no limitations, no comorbidities, his medicine isn't working, but he doesn't want to pay a lot. And my perspective is I want him to be better adherent, I don't want him to have the comorbidities. I don't want him to cost a lot for him either. I want my RCAT results to look good, and I want to control his underlying disease. So again, the patient and the physician's perspective. And the only way to do that is with shared decision-making. It really is an unwritten contract with the patient to use a shared decision-making aid to improve their adherence. And I feel strongly that everyone really needs to try and integrate that into their office practice. There's a study of physicians, and the vast majority said they were doing shared decision-making. And again, they looked at them and only 9%, 100% said they were doing it. Only 9% actually did it in a rigorous manner, going over the nature of the decision, the role of decision-making, explaining the pros and cons, and discussing the patient preferences. The way we do it is simple. We invite the patient to participate. 10% of our patients say absolutely not, you make a decision, but 90% will participate. We explain the options using the decision aid, the benefit and the risk. We ask them to go out and think about it, then come back, and then we assist in the implementation. You know, it's not really a debate about shared decision making. There's no question that in patient preference diseases, preference sensitive diseases, like allergic rhinitis, where it's a choice between SCIT and SLIT, this will help with literacy, cultural competency. If you use a shared decision-making aid, you can understand the evidence that supports each position and the patient. And this doesn't take a long time. To go over the form, I show minutes in our office. I don't do it. My nurses do it. A medical assistant does it. And then I come back and answer questions. There are a lot of decision aids. I think the only one that has been rigorously made for immunotherapy is the one that I referred to. So Randy needs to make a decision. If we provide him with all the information and we make an attempt to greet him warmly, establish a partnership, give him the decision aids, and we follow him up closely, and it's a continual process of this shared decision, and understand his perspective to his illness and his treatment, that's the best way to do it. In our office, we do the RCAT and questionnaires. My medical assistant takes about 5 minutes to do that with the staff. I do a history, talk about his goals, and give him an action plan or a lifestyle plan. I kind of initiate the shared decision making, but it's done after that by my nurse and medical assistant, and then we follow up. I don't think this is easy. It's hard to make the right call on every single patient, but I do think shared decision making is really a good idea. And for allergic rhinitis, go to allergytherapy.acai.org, and you'll find excellent information. So we're going to sum it up by allergic rhinitis. I think I've convinced you has substantial economic burden. It's a major cause of presenteeism, absenteeism. That's how it affects productivity in the workplace. It has a negative impact on quality of life, resulting in sleep problems, cognition. By the way I get at the sleep problems is I often have them bring in their cell phone with about 5 minutes of the husband or wife sleeping or the child sleeping. Worker productivity, learning abilities, we do something called the WAPI, W-A-P-P-I, which is a productivity work and school form that you can use. Patients with allergic rhinitis often don't seek adequate treatment because their physicians don't refer them. They think it's a trivial disease. But I think you'll agree with me after I presented the data that in many patients, it is not just a trivial disease, and it deserves a referral. And it deserves shared decision-making about that referral. Further therapies in allergic rhinitis should address both the nasal and the eye symptoms. For some people, the eye symptoms are really bad. Immunotherapy to SCIT and SLIT will improve not only nasal symptoms, but ocular symptoms and respiratory asthma symptoms. And again, I think shared decision-making works imperfectly to this disease. So I know I've talked a lot, and I want you guys to talk now and answer any questions, or is there any other things you want to discuss? And by the way, I think you're discussing Randy's case.
I have one question about the SLIT, the sublingual immunotherapy. So since it is going into the GI tract, there is like side effects of cramps, nausea, and diarrhea.
Yeah.
Has there been studies of the eosinophilic esophagitis with that?
Excellent question. There is a couple of cases of eosinophilic esophagitis. It's been studied. We certainly, there's a contraindication of using oral immunotherapy with someone who has diagnosed eosinophilic esophagitis. There's no good evidence that it in and of itself precipitates eosinophilic esophagitis. We do have evidence that there's a type of eosinophilic inflammation that occurs when we give people desensitization to food allergens, such as you're going to see on the market in the next year, oral desensitization to peanut allergen. That can cause a type of eosinophilic esophagitis that's reversible when you stop the desensitization or the oral intake of the food allergen. Here, it can, we think, exacerbate underlying eosinophilic esophagitis, but probably doesn't precipitate or cause it. You have to remember the kind of the ideal person to get eosinophilic esophagitis is the patient who has a long history of severe allergic rhinitis and then starts having dysphagia. So that's the kind of setting that you see eosinophilic esophagitis. So we don't think it precipitates or causes eosinophilic esophagitis, but it is a contraindication if you already have it. Did that answer your question?
Yes, it does. And then so let's say you start somebody on sublingual, then you have to keep monitoring them for those symptoms every visit.
Usually those symptoms are extraordinarily rare. In thousands of patients on the clinical study, I think you had less than a 2% complaint of any GI symptoms, which was very similar to placebo. What you do see routinely is, and I've been on oral immunotherapy myself, is itching in the back of the tongue, okay? Maybe even a little feeling like it's swollen, although when you inspect it or examine the patient, you can't see the swelling. And usually you don't stop for that, but just continue and it goes away in a few days. If there is systemic reactions, which are extraordinarily rare, then you should stop the therapy and discuss with the patient further steps. It's safe enough that we start this type of immunotherapy on very labile asthmatics. We would never start SCIT immunotherapy on asthmatics who are very tenuous, but people have started sublingual immunotherapy, especially concurrently with biologics such as Zolar or dipolizumab or other biologics simultaneously with oral immunotherapy, but I don't think any of us would do that with subcutaneous immunotherapy. Any other questions?
One more.
Yes, keep going.
Okay, the switch between the SCIT and the SLIT. So yes. Once you have somebody started on the SCIT and then they want to switch over to the
yes.
easier version, I should say, because not requiring that many visits, not getting shot every time.
Yes.
How feasible it is? Do we have the data on that? And then if there is no efficacy with, let's say, they are on the SCIT, you change it to SLIT, now they are not feeling better, going back again to the SCIT.
That happens all the time in Europe. We don't have any good clinical studies with switching from SCIT to SLIT or SLIT to SCIT. Those studies, some of those studies have been done in Europe and show very easy to go from SCIT to SLIT because of the increased safety margin. Much more difficult to go from SLIT to SCIT. I think you would have to back off considerably and start at a very low dose with the SCIT therapy. So again, not studied well, but moving from SCIT to SLIT is a much easier thing to do. part of the problem is with SCIT, you have multiple allergens where you can desensitize somebody to 5 or 6 allergens, whereas with SLIT, you could do a couple allergens, let's say ragweed and dust mite, but it's expensive to add multiple allergens. It works best in patients that have maybe on skin testing a few allergies, but really historically it's only the dust or the ragweed that causes them major problems.
Mhm.
And one final question, if I may.
Oh, of course.
So once they started on the SLIT, how often do they need to see the allergist? Every 3 months?
Oh, no. Once we have them, I usually see them back in a couple weeks to kind of ask the questions about the tongue swelling and reassure them. And then we see them once a year.
Oh, once a year only.
Oh,
Whereas the immunotherapy, they have a visit scheduled once a year, but they get seen, frequently in the office to come in and get their shots. But we only follow the SCITs too once they're on therapy once a year.
Okay.
Unless they're having problems, obviously. Any questions, Kathleen or Mary Beth? Or Shannon?
nope.
Well, first of all, I want to thank everybody. How can we improve it in the future? I'll start with Shannon.
I want to thank you for this. This is absolutely great. It's very interactive, which I like. I love having everybody on the panel. We all have like a little bit different backgrounds. So I've been able to learn a lot from not only you, but all the other panelists. So I think this is really good. And I absolutely love doing a case study. So I don't know of anything right off the top that I would say to do differently, because this is my first time doing something like this and I really enjoy it. I think it's really well done.
Okay, Vishal.
Yeah, I think this is great. This was amazing. And I'm going to try this with my fellows so that when I'm giving a talk,
Good.
the cell phone. Well, this will be very difficult to set up the system, but this will be good to try it on them so that they are paying attention. They are all there. I can ask them for their input, questions. It's great for the attention span. This is wonderful.
Great. Mary Beth.
Well, I really enjoyed it. I wish you guys could see my beautiful face. I don't know what happened to my camera. But no, I enjoyed this. I enjoyed being able to see everybody involved. Anything different? Not offhand. Can't think of anything. I want to thank you for this opportunity.
Thank you, guys. And Kathleen.
I think that problem-based learning, the Socratic method, really works well, and it brings out the best in education. I think that the people that we're going to be using this with will really rack their brains, and really use everything that they have to think of things to do for Randy. And it's painless. You really get involved in it. It's not like sitting listening to a lecture or a PowerPoint or some crazy thing where you might want to doze off or something at this hour of the night. So I just thought it was fabulous. And thanks again for inviting me.
Well, we want to thank all of you. I want to thank all of you today for participating and observing and interacting in our problem-based learning discussion of difficult to control allergic rhinitis. This is a CME program, and again, I want to thank all of you for participating today.